All right. Good morning, and welcome to this morning's discussion on the Psyfeld episode, the Bris, right? Sure, we're on the same page. All right, so where would you like to start?
I think the Moyle showed a lot of aggression.
What did you see?
It seemed like potentially like explosive, where he at some points seemed okay, but then at other points just like blew up on people around him.
So the observation looks to be intermittent explosiveness, right? And I think one of the things that will often come to clinicians' minds first is a condition called intermittent explosive disorder, which is or was formerly categorized in a chapter titled the impulse control disorders, right? And just for proper context, what are some other examples of the impulse control disorders? Well, I want you actually, that was my next question. So hold on to that one.
When conduct disorder is one?
Conduct is one. Previous to 2013, it was not. But conduct and oppositional defiant disorder have been subsequently included into this chapter. They are the only two, well, I mean, any illness can be diagnosed in children, but they are the two primary child adolescent illnesses that are included in this new chapter. Others?
Disruptive mood dysregulation.
Disruptive mood dysregulation disorder. I'd have to double check. I'm pretty sure that's in the mood the mood disorders chapter. Yeah. Again, but another child adolescent. You guys are killing me. What adult psychopathologies comprise what was formerly known as the impulse control disorders, other than intermittent explosive disorder? ADHD? No, not ADHD. But again, similar to bipolar, hold that answer because that's where I'm going with this. Obsessive compulsive disorder? No. Antisocial personality? Nope. Other disorders of impulse control include conditions like kleptomania, right? Right? Pyromania, right? And one was trichotillomania, but that also has now been punted, DSM-5, to a different chapter, specifically the obsessive compulsive and related disorder chapter. So even that one's been farmed out, right? So that's the type of condition we're struggling with here. And intermittent explosive disorder is another example. Right? Now, in the previous edition of the DSM, the chapter had a much better title, Impulse Control Disorders, NEC. Now it's the impulse control and dysregulation disorders. I'm probably messing that up, but that supports my point that the change in title is not helping anybody. Most importantly, we forget what NEC means because it's no longer part of the chapter. It's not part of the title anymore. What did NEC stand for? Not elsewhere classified. Meaning that when an individual presents with clinically significant deficits in impulse control, the clinician should always think that it's part of a larger or manifestation of a larger disorder. And bipolar and ADHD would be at the top of that list. Right? That's the way to think like a clinician. When there is no other disorder to explain the patient's behavior, specifically their impulsivity, then you're looking at that specific set of disorders, aka the impulse control disorders, not elsewhere classified, such as kleptomania, pyromania, as well as intermittent explosive disorder. With that as a background, what is your gut as to what's going on? And we can even take this as a stepwise approach. Do you think it is a larger disorder, or do you think that such a disorder such as bipolar isn't there, and this is probably along the lines of an impulse control disorder that is not elsewhere classified?
I think the changes were so quick and so like rapid. I wouldn't immediately jump to bipolar.
Okay.
I would jump to more on the anxiety disorders.
So you found them anxious.
Yeah.
Okay.
I can't tell if it's intermittent explosive disorder or always explosive disorder.
Yeah,
honestly.
and that is unfair because we only see a slice of time here. to my knowledge, the Moyle is not in any other episode over the 9 seasons of Seinfeld. So we don't get a history, although that would be a question we must ask either him or his social support. Because if this has been who he is since, 7, we're going to have a little bit of a different impression than if we're told, no, you know what, when he showed up today.
The other thing I kind of had a thought about or question about, I could see some impairment in his relationships, but it seemed like there wasn't an impairment in his job functioning at the end of the day, because it seems like the circumcision was actually done successfully. Was it unsuccessful?
Yeah, highly.
Like he actually didn't circumcise the kid, right? He just circumcised Jerry's finger. Is that all that happened? Okay. I was confused at the end because I thought I thought he still did the circumcision and the kid was okay.
I have to look at that again.
I don't think so, because that's why they were like praising at the end, because they're like, oh, you saved our child.
Oh, okay. I was confused about that. Which maybe it does affect his function, which would make sense.
But again, another question I think we would obviously ask, can you tell me a year ago, a decade ago, give me an idea of what was going on then, if anything, right? We would need to know that. So maybe intermittent explosive disorder, maybe some issues or deficits pertaining to impulse control that may be itself classified under another condition, bipolar, for example. I don't know if he's acutely manic, but it sounds like there was an anxiety component to it. So other thoughts about the Moyle here?
Maybe you can throw in some specific phobias too, like blood. I think he was at the hospital a little alarmed. Previous photos, maybe Jerry's blood, about getting on.
And Jerry talked about that too, right? So there are 4 subtypes of specific phobia, other than other, which of course is the grab bag potpourri. What are the 4 subcategories of specific phobias? Agoraphobia is another form.
Okay.
It's another mental disorder based on an irrational fear, but it is not considered to be a subtype of specific phobia.
Claustrophobia?
Claustrophobia is along the lines of agoraphobia, enclosed spaces, as defining agoraphobia. So again, not necessarily a subtype.
Social phobia?
Social phobia, same thing. You guys are good. Well, my next question was, talk to me about the other anxiety disorders. So you guys are all over this.
Well, so like we described blood.
Blood injection injury is one, right? Now, whether it's actually due to the puncture or whether it's blood itself may differentiate, right? Blood itself would be more along the lines of other, but blood injection injury when people vasovagal is a subtype. 3 other subtypes. And here we're categorizing the phobic object. So on the shelf exam, the good news is that you are not going to be held accountable anymore of the 546 different names applied to the specific phobic objects. That's the good news, right? But you might have to come up with one of those subtypes, right? And blood injection injury is one. Animal subtype, right? Animal subtype. That probably doesn't include insects.
Nature,
Sorry?
nature and environment.
Environmental, good. And the other one is situational. So, and again, if your patient doesn't neatly fit into one of those artificial created subtypes, then they are specific phobia other, which is not likely to be a shelf answer, but certainly could be a diagnosis. Clowns, for example. I mean, very common fear, but certainly doesn't fit unless they're, puncturing you with a needle or something. So I think Jerry's behavior especially does focus on the potential for blood injection injury type. What other behaviors you want to talk about that you've observed or want to discuss on the Moyle or the Bris? Let me continue a little bit about anxiety disorder, since everybody is a week away, right? The shelf exam? Or is it 2 weeks? I'm accelerating things for you. I apologize. All right, 2 weeks away. So an individual presents to you with avoidance behavior, just throw out some differential for me. And yes, it is clinically significant. So I'm not trying to trick you here. And it's not due to a substance, and it's not to another medical condition. So I want us to remain focused on the anxiety spectrum disorders.
Specific phobia.
Specific phobia, clearly, right? Phobic avoidance for specific phobia. That would be your differential diagnosis. On your shelf exam, you will then look for that phobic object and hopefully be able to subcategorize within those 4 different categories we discussed. That's what you're going to have to look for on your exam. Next.
Panic disorder?
Panic disorder. When individuals decide that they are not going to leave their house for fear of having a future attack, what is that called? There's panic disorder with?
Agoraphobia.
Yes, agoraphobia, right? Now, panic disorder may be with or without agoraphobia. And certainly individuals who present with avoidance behavior, avoiding going out due to the fear of a subsequent panic attack, are demonstrating aspects of agoraphobia. That's the phobic avoidance that's attached to panic or panic disorder. Okay. Now, what exactly is the fear? And that's hopefully you're going to ask this to your patient when they present and say, I haven't left my home in a year and a half. And you identify that about a year and a half ago, they were diagnosed with debilitating recurrent panic attacks, ruling in for panic disorder. And you ask them, so what is your fear? What on the shelf exam in that vignette are you now going to specifically look for?
Go ahead.
Yeah, it's mostly they're scared of having another panic attack.
And more specific to that. That is true. So you're 99% there.
They're having a panic attack and not being able to like escape the
That's it.
space.
That's it.
Okay.
So it's a little bit more than just having an attack. It's what that attack is going to do to me, embarrass me, and not being able to escape. Right. So that's agoraphobia, which may or may not be related to panic attack. So you could have panic disorder with or without agoraphobia. You can also have agoraphobia as a standalone diagnosis, because individuals with Tourette's, irritable bowel, any reason, avoid going out for fear of embarrassment or escape, or not being able to escape. Good. Differential beyond agoraphobia and specific phobia. What else do you got? How about if I told you the exact same thing, but I just tweaked my fear a little bit and said, it's not necessarily about not being able to escape in time, doc. It's more about the actual social situation itself that invokes my fear. Then what is that? Good. It's social anxiety disorder. Right? Social anxiety disorder. Now, here's the test question, right? A professor who is held in incredibly high regard by their medical students has difficulty getting behind a podium in the East Lecture Hall and presents with a chief complaint of avoidance behavior. I'm not sure if I'd use that terminology, but that's what you surmise. When you ask them what their fear is, they tell you that because of where the door is situated and because that one door right behind the podium doesn't work right, if they were to have any signs and symptoms due to blank, they're very fearful of being able to escape before becoming incredibly embarrassed in front of a room this size, filled to capacity as it is. Single best answer.
Performance only.
Performance,
Stage fright.
stage fright, performance anxiety, stage fright and social anxiety disorder, comma, performance subtype are the exact same thing. Right? But this is agoraphobia, right? I set you up, right? I gave you the most common presentation of social phobia, specifically performance subtype, but the fear was clearly not being able to escape in time. Be very careful. Please read your shelf question very closely. Right? What is the fear? And of course, in a clinical setting, listen to your patient. If they tell you that they're having performance anxiety, you have to ask what the fear is. And if during performances, the way things are set up on the stage, at the bottom of that lecture hall, escape would be difficult. Boy, it sounds an awful lot like agoraphobia to me, despite the fact that it's in the setting of public speaking. So read the question closely. Other part of the differential of someone presenting with clinically significant avoidance behavior.
Avoidant personality disorder.
Yeah. So avoidant personality disorder, right? Individuals who have avoidant personality disorder have a much more chronic, debilitating course. They usually adapt to it, and they usually present to clinical practice with a chief complaint within the depressive anxiety spectrum because of the sequelae of avoiding and the fact that they're conflicted, right? So these individuals want to be out there, but it's just way too stressful to have interpersonal contact, so it's easier not to. So they live by the credo that it is better never to have loved at all than to have loved and lost. If I don't put myself out there, I can't get hurt, and they're right. So that avoidance behavior gets reinforced, right? And it perpetuates the behavior, and it could lend to very chronic personality traits, and therefore serving risk or placing the individual at risk for avoidant personality disorder. How does that differ from schizoid personality? Sorry?
They're happy being alone.
Yeah, they're happy or content being alone. That is their preference. And they actually demonstrate anxiety, frustration, etc., when they are made, for whatever reason, to be in the company of others. Right? Schizoid personality. A little bit of a red flag on your shelf exam. Individuals with avoidant personality tend to present with signs of depression, anxiety. Individuals with schizoid who present, single best answer on a shelf exam, usually present through a third party, right? So the Board of Health comes because of the avoidant behavior resulting in blank, and it's that blank that gets them to the clinic, right? So not usually not a self-referral, right? So just a hint on shelf exams. Any other in a differential of clinically significant avoidance behavior? There's one more biggie.
Maybe like schizophrenia, possibly.
Possibly bigger than that. I mean, more straightforward than that one though. Post-traumatic stress disorder, and therefore acute stress disorder. So you want to count those as 2 or 1.5, right? 1 month cutoff. But those are 2 other illnesses that have avoidance criteria built in them. Of course, what you're going to look for in your shelf exam is not only the avoidance behavior, but other signs and symptoms that are more specific to PTSD and are not part of the definition of either social anxiety disorder, agoraphobia, or any of the other conditions we discussed. So when you see avoidance behavior that is clinically significant with nightmares and flashbacks and hypervigilance and an exaggerated startle response, and impaired concentration, difficulty sleeping, intrusive thoughts, that's post-traumatic stress disorder. If it's between 1 day and 30 days, we're talking about acute stress or acute stress disorder. Any other thoughts, observations, or questions pertaining to the MOIL? What other observations do you have about the Bris?
Would you consider Kramer's like seeing a pig man? Would that be like an illusion maybe because he saw something similar?
Yeah. I think Kramer's subplot is a nice door to talk about perceptual disturbances in general. And on a test, I think it's fair game or to expect a medical student in their 3rd year to differentiate between an illusion and hallucination, specifically a visual hallucination. Okay, and what is the difference?
Illusion. Illusion has like an external stimuli, whereas a hallucination has no stimuli.
Right. So an illusion does have an external stimuli that is misinterpreted, whereas that is not the case for hallucinations in general or visual hallucinations in particular. Right? So they're unprompted. All right, anything else for Kramer?
It was definitely calling me like actual like Bris ceremony, like not culturally appropriate, even though it was. And he was saying that it was like barbaric and things like that, which is a very culturally appropriate behavior.
Yeah, and I think Kramer's behavior or disregard for, again, prompts the discussion that we did touch upon, I think, as recently as last week, and that is this differentiation between culturally sanctioned behavior or beliefs versus culturally bound syndromes. right? And if you're ever concerned about what's the difference and how to identify this in a shelf exam, focus on the actual terminology, right? In one term, you have the word sanctioned, and in the other, you have the word syndrome, which connotes some level of abnormality. Right? So culturally bound syndromes are geographically isolated, but within the isolated culture are considered to be abnormal, hence why they are syndromes. On the other hand, that is not the case for culturally sanctioned beliefs or behaviors, right? There, while you do share the premise that it is geographically isolated, the differentiation is that they are in fact sanctioned. They are completely normal within the context of a practiced culture, etc. Right? So Kramer's behavior certainly allows us to discuss that. I brought this up last week. I'm going to say it again. For culturally bound syndromes, the vast majority of the time, 90+% of the time, you will likely have to identify the syndrome and choose it as the single best answer. Right, so become familiar with those terms. I've never seen any more than a single question on a test pertaining to culturally bound syndromes, but boy, if you could just review that list of those syndromes and be able to identify it, it's an easy answer. On the other hand, culturally sanctioned beliefs, 60-40, there's going to be, or the answer is going to be you identifying that it is completely normal. No further action needs to be taken. Nothing to do. No treatment necessary. 60+% of the time, that's what they're looking for. On the other hand, a smaller percentage of the time, you may have to actually identify the clinical term describing the sanctioned belief. And the example that I gave last week was hoodoo with an H. That's just but one example. Right? So 60-40. Any other observations about Kramer here? Just a quick comment. Of course, Kramer's subplot and his becoming the Godfather was an allusion to the movie The Godfather, which, of course, starred James Caan, who were the works of which we're actually discussing today. So that was the actual reason why I chose this particular episode and Stephen King's Misery for our noon discussion. And yes, there is psychopathology in The Godfather, way beyond the context of the time we have allotted. We have about 5 minutes left in this discussion, so we can't get into The Godfather. Other observations on the Bris? Any other characters catch your eye?
I was just going to say previously, it's not like psychiatric, but it's psychological. It's like bystander effect at the Bris, like how everybody knew that Moyle was like not acting appropriately, but the only person who wanted to speak up was Kramer, which is just like funny and ironic.
Right. Yeah, and it's interesting because you do have that quote unquote mob mentality, and there's been studies out of Stanford to show that the group effect is highly influential in situations like this. Right, the Stanford Prison Experiment by Zimbardo. Again, it's that is a gold standard discussion in Psychology 101 classes. And the one person that defies this, the one person that would actually have made that study worthwhile would be Kramer. And the only reason why, and of course this is the twist, is that he's absolutely like not in tune with what anybody's ever thinking, right? Because of schizoid traits versus schizotypal. So that's the irony here, is that the individual who has clinically significant deficits in social contact and connectedness is the one to sidestep, that group effect. Only 5 minutes left. Any other or final thoughts? All right, we'll leave it here then. We'll come back at 8:30 and a different link and begin table rounds then. All right, thank you.